Why did they just put them on? You put them on alpha blocker, they're better in a week. They'll go for 5-7 years. They go into retention if you're not careful. So please, I'm just asking you, consider the use of finasteride. It is your friend. Has almost no side effects. 1 out of 300 men erectile dysfunction. 1 out of 300 men nipple tenderness, which is breast growth, and you have to stop the medication. I know the answer. Foreskin diners. Screening for prostate cancer, the controversy that doesn't die. This is New England Journal of Medicine 2000. You got to know a little bit of history about this. This is from the American Cancer Society. What happened? Why was there a spike? PSA came out in 1987. The first one I could order was November of 1989. Use PSA to follow the treatment for prostate cancer, for which there is nothing better. It is exquisitely sensitive. Somebody should get a Nobel Prize for figuring it out, as far as I'm concerned. Well, that led to a spike in discoveries of prostate cancer along with screening. This was the survival, the death rate from prostate cancer. The last they had is 2010. It used to be basal cell carcinoma always sitting on top of this thing for 30 years. They finally figured out nobody ever died of basal cell carcinoma. Prostate cancer is the #1 cancer in men, #3 cancer killer. State of Wisconsin, 3,570 estimated this year, of which there will be 570 deaths. Screening controversy. You have to understand a little bit of the history of why we screened, or why we started to screen. In the old days, we found prostate cancer by doing a rectal examination, feeling a lump. If the lump was positive, we did a biopsy. Because a biopsy in the late 80s, early 90s, there was a major shift towards doing surgery. Dr. Van de Croy did not be offended that the type of radiation therapy they used back then didn't work. I'm sorry, didn't cure the number of people that they do today. Now Dr. Van de Croy uses 3D conformational IMRT. I think it's as good as surgery in many, many cases, and not better in some. So a tip of the hat to you guys. But back then it was not the same. The radiation wasn't the same, and actually the surgery wasn't the same. But we feel a lump, we do a biopsy, we found cancer, we took them to surgery. I would talk to them ahead of time. If you have positive adenopathy, you want me to remove your testicles at the same time. At least 40% of the time they had adenopathy at the time of surgery. So we knew by finding you could feel it, at least 40% of the time they're incurable. If you have adenopathy, you're going to die of prostate cancer eventually. There's no cure. This took all of us by surprise. 2012, U.S. Preventive Services Task Force grade D recommendation, shouldn't do it. And urology took this very seriously. They based it on the U.S. prostate, lung, colorectal, and ovarian study. There were 76,000 men in it. This is out of our textbook showing the criticism of that study. 40% of the men in the control arm were pre-screened. They weren't a control. There was poor biopsy compliance. And essentially, the study didn't do what it was designed to do. There's conflicting results from other randomized controlled trials, the 2 large European ones. The Swedish one started first, and some of these Swedish patients are in the European randomized trial. The study that was done here, no difference. 21% reduction in prostate cancer mortality in 13 years, 44%. And early in both of these studies, they were just doing 6 biopsies of prostate. We changed to 12 biopsies because we found more cancer. And so if they had done 12 in the early portion, they probably would have found more, and there probably would have been better reduction. So why is the U.S. study off? I don't know. I'm not here to criticize or run these guys down. You remember a week and a half or 2 weeks ago, they just came out with new recommendations. This is off their webpage. A little bit has changed. They now give it a C recommendation. Said you're supposed to talk about it to men 55 to 69. Over 70, you're not supposed to offer it. This is also, and I have a problem with this, and it just angers me. It says 60% of the 80 men that have treatment, be that radiation or surgery, 60% or more will experience serious complications. And I'm sorry, it doesn't jive in our randomized trials that we see in our literature. You know, to me, this is a little bit over the top. There are 16 members, they're volunteers, quote unquote. They are actually appointees of a bureaucrat in the healthcare arm of the government. The recommendations are based on vigorous review of existing peer review articles. This is not a transparent process. We don't know what they're reviewing, how they're reviewing, and they give no justification for the recommendations. They have not addressed their previous recommendation, or what to us is a glaring problem. So here comes the NCCN guidelines. These are the members of the NCCN panel. They are extremely apparent, and I think because of that, maybe a little bit more legitimate, I'm not sure. I'm not here to criticize the U.S., but it just bothers me because it's created controversy. The patients may not be able to trust us because the government's saying one thing and we're telling them another, and I don't like that. We have science. We should be able to do better than that. So here are current guideline recommendations. They are in conflict. The AUA in 2013 said talk to the patients. The Europeans say talk to the patients. The American Cancer Society talk to the patients. These guys seem to have switched now from over here. The Canadians still don't offer it. We don't want to abandon screening. There's evidence that if we abandon screening, we eliminate overdiagnosis, but 2 times more metastatic cases and 13 to 20% increase in preventable cancer deaths. We want to try to do this better. We want to try to reduce overdiagnosis, better selection of patients, better screenings and biopsies, better treatments. We want to avoid unnecessary biopsies, which about 7 out of 10 that we do right now are unnecessary, and we don't want to find insignificant cancers. This is out of the prostate cancer prevention trial when Proscar, which is finasteride, was going to lose its patent. They did a trial to see if finasteride would prevent prostate cancer, and it will. That's the one you always hear, that finasteride causes cancer. It actually is more effective at preventing the low-grade tumors and only the high-grade ones snuck through. All these men got biopsied, whether they had cancer or not. And this slide's up here just tell you there is no PSA where you don't have cancer. You can have cancer even with a very low PSA. The unfortunate part, the more aggressive cancers tend to make less PSA. PSA density, this is something we do with our ultrasound machines when we measure it. It may help us know who to biopsy a second time if we need to biopsy them. PSA velocity, how fast it goes up over time. I'm sorry, I'll try to talk a little faster. This is one that really seems to help. You need 3 PSAs scattered over an 18-month period. If your PSA is going up more than 0.35 per year in a younger man, you may be worried that he has prostate cancer. He may need to go to biopsy. In older gentlemen, 0.75 is sometimes used as a cutoff. PSA velocity risk count is just putting several PSA velocities together. Percent free PSA. PSA is bound to protein, some of it's unbound. There seems to be a little bit more in prostate cancer patients unbound. Remember that it only works for a PSA between 4 to 10. If your PSA is 20, don't order percent PSA. If your PSA is 2.5, this thing is not going to help you. Only works for PSAs between 4 to 10. You want percent free under 25%. Up over 25%, I told you wrong. Not under 25%. AUA recommendations, no screening in men under 40, no routine screening in men 40 to 54. There's no studies to justify doing it, but there's a study going on right now. For men 55 to 69, talk about it, decide what to do together. Do not do community-based screening. The reason they put that in there is because you can't have that discussion. Should consider a man's life expectancy, screening every 2 years, selective screening for men over 70, or for men with a life expectancy of less than 10 years. And one of the things that we'll see in the office is Mr. Jones will come in, he's 62 years old, he's got a PSA of 9. Well, he's had 2 MIs, he's got cardiac stents in, he's an insulin-dependent diabetic, he's anticoagulated, he's had a stroke. Well, what do you do with that? We see that, or somebody who's 85 years old with a PSA of 12. They're worried they got cancer. So be a little careful. If their life expectancy is less than 10 years, there's a real push not to do PSA and PSA screenings. This is from the NCCN guidelines again. They use a different PSA. They suggested a PSA of 3 based on their research. Talk about it, decide what to do. If he's 45 to 75, over PSA suspicious, do a biopsy. Repeat testing. Remember, prostate cancer is a slow-growing disease. It doesn't hurt to repeat. You know what you get when you cross a vampire with a snow? Frostbite. When the dual biopsy. PSA is over 3. You repeated the PSA, the digital rectal examination. You don't think he's got benign disease. Dual biopsy, see if there's cancer, or do a follow-up. Repeat the PSA. It's a slow-growing disease. If he's got cancer, the PSA is going to continue to go up. Or do a percent-free PSA, or the newer test coming online, K4 and the Prostate Health Index. This is a mathematical formula. It's put out by a company. You send them the blood, they do it. It's going to help us in terms of probably not the initial biopsy, but later biopsies. The problem is not showing us problems with the high-risk disease like the K4 is going. Here's a PSA of 4.4. That's not too bad. Percent-free PSA is 21%. Well, that's not bad. Over 25, you're not going to biopsy. But when you put in the Pro 2 PSA, you become a 51 or 52% chance of having cancer. Another one's PSA is 10. Oh my goodness, we better biopsy him. Percent-free PSA is 10. Oh my goodness, it's under 25, we better biopsy him. But he's only got 11% chance of cancer, so that may lead you to not do his biopsy. Now this is not helping us with the high-grade ones. K4 score is a kallikrein markers combined with the total PSA, free PSA, intact PSA, and a kallikrein form, which is on the same gene as coding for PSA. Combine that with the age digital rectal and a proprietary mammogram, and they come up with a higher chance of having high-grade cancer. This is the cancers we want to find. These are the cancers we can help. So you're going to hear more about K4 scores, and they have very much a linear relationship in finding the high-grade cancers. Repeat biopsies. We do your biopsy, we don't find cancer. The old party line is you keep checking the PSA continues to go up. Keep doing biopsies till you find it. Well, it's changed a little. If you have cancer, figure out what to do. Atypia, which is probably pre-cancer, you re-biopsy, and this is the change, high-grade PIN, high-grade prostatic interepithelial neoplasm. There are two forms, high and low grade. Low grade is meaningless. If you just have one focus, don't do anything, just treat them like benign disease. If you have multiple foci, treat them as suspicious. And I know you don't need to do that. This is a urinary marker. It's a non-coding messenger RNA. You do a prostate exam, massage the prostate, collect the urine, send it off. It's going to help us, again, with who to re-biopsy. Confirm MDX, hypermethylization of tissue around cancer. You may not have found the cancer, your needle may have missed it, or there may be tissue changes around it, and you can get a report that tells you may want to do another biopsy. And these are several other markers that may come on the market soon. There's a lot of research in this. The second reason I wanted to give the talk, multi-parametric MRI. I am not a radiologist, but you're going to see this come to the front of prostate cancer fairly shortly. PRAD scores, I'm not a radiologist, but if you have a PRAD score of 1 to 2, significant cancer unlikely. You get up to these 4 or 5s. Targeted MRIs, I'm going to show you in a minute. NYU, New York University out in New York City, if you come in with an elevated PSA, you're going to get a K4 score, and they're going to do an MRI before they do your first biopsy. We can't do that right now. We have difficulties getting the initial MRI covered. Fusion MRI. We're looking at this technology. It will be adopted here at some point. This is an MRI picture showing a PRAD 4 or 5 lesion. You try to figure out where that is on your ultrasound and direct your needle there. It is not as easy as it sounds. Summary, multiple variations of PSA, greater specificity, sorry, I can't speak. New PSA-based markers. E3 is an FDA approved, confirmed MDX, MRI targeted biopsies. We do that for the second biopsy now, we can't do it for the first. One size fits all doesn't work. We don't want to throw out the baby with the bathwater. We want to get rid of false positives, overdiagnosis, overtreatment. Why did the turtle cross the road? First joke my son ever told me when he was 6 years old. Get to the Shell station. Prostate cancer. Don't do anything. Active surveillance or just treat it. Watchful waiting. You've got prostate cancer, your life expectancy is not that great, come back and see me and it bothers you and we'll treat you. That's a little different than what watchful waiting used to be. This is the big one, active surveillance. AUA is pushing this. A lot of men are going to go on to this. We want to actively monitor the course of the disease. There may be 10 to 12 year lead-in time from the time of your biopsy to the disease is going to bother you. Why should you have to deal with the morbidity of the treatment unless you have to? And many men aren't going to have to. I didn't look this specific study up. I don't know who's doing autopsy studies in 1994, The original studies that I used to see were from the 60s, and there was a high percentage of men in those autopsy studies with prostate cancer. It goes up the page. I wanted you have to know a little bit about staging. T1, we found those in TERPs. T1A, we usually cure them with TERP. T2B, these fellows are going to have troubles because most of the prostate's cancer. This is how most of them are. We find them because of an elevated PSA. Palpable tumors, T3Bs, get a little bit bigger. Gleason's scoring system. Gleason's was a pathologist at the VA over in Minneapolis, St. Paul, and he came up with this system in the 70s. It still works today. Gleason's 1, Gleason's 2, 3, 4, 5. The more angry it gets, the more aggressive the tumor is. Going into active surveillance, low-risk patients, T1C, can't feel it. Gleason's score under 6, very slow-growing cancer. PSA is low, fewer than 3 biopsies. Very low risk. Low risk, intermediate risk, you get to be bigger tumors or higher Gleason's scores and higher PSAs. A number of these studies are going on right now. This is one that just came out. This is really old stuff. I think it came out April 2017. Gosh, how did I get it in here so fast? I did it last night. It's not in your packet. 421 men. All these patients are rebiopsied a year to 18 months after they're put on active surveillance. They all have cancer. You rebiopsy to see if the cancer is changing, PSA is changing, or the MRI is changing. This study just shows it doesn't matter if you biopsy in 8 months. If you biopsy in 8 months, a year, or greater than 13 months, they're all about 20% are going to be upstaged and go into therapy. Active surveillance, University of Toronto has been doing it about the longest. Low risk, T1Cs and T2Bs. Remember, you can feel this. So it's not, there's no standardization of what's low risk and high risk. You make up your own protocols right now. Intermediate risk. And overall survival, 50%, 66. This is just overall survival. It has nothing to do with cancer. These are the cancer-specific survival. 88% of them in the intermediate risk are still going 14, 15 years out, 96%. Metastatic free survival. You get mets, you're going to eventually die, but you're going to need treatment. But not too bad. Out at 16 years. Probability of, what's it say, remaining on active surveillance. Again, I told about 20% a year are going to switch, so number will fall. This is, I put this in to show you the difference. Gleason's score 3+4 versus a score of 4+3. These patients don't do as well. It's that sensitive. It works that well. That's amazing. All right. Have your biopsy done, go into active surveillance or have surgery. And I'm just going to skip these because we're going to run out of time. There's a couple more things I want to get to. Focal therapy, there's a group that's thinking that your primary lesion, you have these little satellite lesions that don't mean anything. You can treat it with a laser and an MRI. I don't know who's doing this. You can treat it with HIFU. Remember I told you earlier about the high-intensity ultrasound, and the Europeans are doing this. It's not FDA approved in this country. I asked Dr. Tubison why, he said it doesn't work. It is approved for the treatment of BPH. And you can put electrodes on either side of the primary lesion. But I don't know if this is going to be functional. I can remember back in the days when I was doing a large number of radicals, I'd get one biopsy positive, we'd go to a radical, present a tumor board, the entire prostate's cancer. How did you ever miss it? You could not get it. Drugs and such, doxycycline, abiraterone, enzalutamide, radium, simple T. Doxycycline is chemotherapy. I'm not an oncologist. It is approved for the treatment of metastatic prostate cancer. We have a patient right now, his PSA is 550, he's got mets everywhere. He will live probably another 3, 4, 5, 6 months if he can tolerate this. I've always wanted to use this quote. It must have been rough living in Bible times. Testosterone. The treatment of prostate cancer is testosterone. Huggins was a general surgeon, moved to Chicago, took up urology. Stevens, I don't know who he is. Hodges trained under Huggins, went out to Washington State, became department chairman out there, and eventually died of prostate cancer. Huggins won a Nobel Prize for this. He was the second surgeon in the history to win the Nobel Prize at the time. He proved prostate cancer was sensitive to testosterone withdrawal therapy. These are the ways of getting rid of testosterone. Orchiectomy, which we have very little to do. The medications that are anti-androgens, Casodex being down here, the big one. Enzalutamide just added. Diethylstilbestrol, very cheap, very effective drug for lowering testosterone. The problem is it causes blood clots, heart attacks, and strokes. When I was just entering med school, there was a big debate. Use 1 milligram, it wasn't enough to treat the cancer. 5 milligrams, they're all dying of heart attacks and strokes. They settled on 3, eventually it went away. Lupron came out, we used Lupron. Degarelix is a wonderful drug for treating it. Ketoconazole, if you want to use it, you have to give them also, you have to give them prednisone with it, I think. Amiodarone's the newest one, and I just want to get through this last little bit. Enzalutamide, it's going to block this part, and it's going to block this part, and it's very effective on it. None of these are home runs. You're going to live another 3, 4, 6 weeks longer. Amiodarone, the same way, it's working. It's a selective inhibitor. Let's show you. It inhibits the CP17, so you lose all this. So you're going to lose your cortisol, so you have to give them prednisone also if you're going to use it, but they're going to live a little longer. There's not a trial using both of these at the same time yet. Simple T is, if you will, an immune therapy. It's going to get you about 3 or 4 months a little further on. It's costing over $75,000 for that. Radium 223, I almost asked Dr. Vanderkooy why we didn't use this on the patient with the terrible pain from his multiple tumor mets, but you have to have castrate resistant, and he hasn't been hormonally manipulated yet. This is what is it? It's an alpha emitter versus a beta emitter. Strontium we used to use and had more bone marrow suppression with it. But it's a way of treating bony pain if you don't have visceral metastasis. And then this is castrate prostate cancer. This is what we go through trying to figure out how to treat these castrate-resistant patients, because they're the ones that are in the process of dying from prostate cancer. And that's all I had to say. I'm sorry I went 5 minutes too long. I tried to do it better. That's not 100%.
Yeah, is there a genetic predilection for prostate cancer?
Is there a what?
A genetic predilection for prostate cancer?
I still can't.
Is there other families? Prostate cancer families or not?
Yes. There is a genetic component to the disease. And so if you're African American or African heritage, or if you have a family history,